Next, we explore a transformative advancement in surgical care. Welcome to Dr. T. Sumana, Senior Consultant, Robotics and Laparoscopic Surgeon in Gynecology. Dr. Sumana has been honored with numerous awards, the latest being the Excellence in Clinical Practice 2025, and has several academic contributions to her credit. I also
Warm good morning to everyone who are on the stage and also off the stage. Myself, Dr. Sumana, today want to tell you about the robotics in gynecology. The robotics in gynecology, it is a present and future of minimally invasive surgery. It is an evidence-based exploration of current practice, emerging technologies, and transformative potential of AI integration surgical systems for international gynecological surgeons and clinical decision makers. And now there is a 4-port surgical robotic system, but now what is the evolution in women's surgery? Robotic surgery Robotic surgery in gynecology enhances precision, dexterity, and surgeon's discomfort, enabling minimally invasive management of complex cases that previously required open approaches. The field has matured beyond simple adoption to focus on innovation and optimization. Now today's transformative shifts include single-port systems. It reduces the visible scarring and potential pain, and the AI integration for real-time decision support and surgical guidance, and also a competitive marketing dynamics. It driving down the cost and expanding access. And coming to the robotic Now, coming to the historical evaluation from concept of clinical standards. The Dawn Surgical Robotics, the master robotic system introduced to extend minimally invasive surgical capability to complex cases requiring fine dissection and suturing. It is in 1990s, it was started. And early prototypes demonstrated feasibility but faced significant technical and acceptance hurdles. In 2000, FDA was approved and adopted the Da Vinci surgical systems. It receives clearance and for the gynecological procedures. Rapid adoption in tertiary centers begins with the early case series demonstrating safety and feasibility for the hysterectomy and the myomectomy. In 2010, there is a evidence generation and refinement in the surgical systems. The large registries and comparative studies emerge. Systematic reviews show equivalent outcomes to laparoscopy with trade-offs in cost and operative time. Platform refinements improve the instrument articulation and vision systems. Now we are in 2020 and 2025. There is an innovative acceleration. The single-port platforms launch, multiple competing vendors enter the market, and AI integration begins with camera control and instrument tracking. First telesurgery demonstrations completed, the field enters a transformative phase. So, robotics, why in gynecology? The gynecological procedures uniquely demand the fine suturing, in confined spaces and complex lymphadenectomy and precise dissection around critical structures like urinary bladder and ureters. Robotic addresses these challenges through wristed instruments and tremor infiltration. Now, what are the core technical advantages of robotic platforms? First and foremost is the wristed instrumentation. 7 degrees of freedom enable natural wrist-like movement inside the body, facilitating complex suturing and intracorporeal knotting that would be extremely difficult with rigid laparoscopic instruments. And it provides a stable 3D HD vision. Surgeon control camera provides immersive stereoscopic depth perception with 10x12 magnification. The stable platform eliminates assistant variability in camera positioning and enables precise identification of tissue planes and anatomical landmarks. And there will be a superior ergonomics for the surgeons. Console-based surgery dramatically reduces the surgeon's fatigue, allowing comfortable seated positions with optimal visualization. This ergonomic advantage extends surgical careers and maintains peak performance during lengthy, complex cases. And tremor filtration. Motion scaling and filtering eliminates physiological hand tremors and allows fine movements to be scaled for microsurgical precision. So, what are the limitations and trade-offs? There are critical considerations. While robotic surgery offers compelling advantages, clinicians must understand significant limitations that impact clinical decision-making and institutional adoption strategies. The first and foremost limitation is loss of haptic feedback. Current systems provide no tactile sensations, requiring surgeons to rely entirely on visual cues for tissue tension and instrument pressure. Second is economic barriers, higher capital investment, maintenance contracts, and disposable instrument costs create financial barriers. Third is access inequity. Technology remains concentrated in urban tertiary centers, creating disparities in access to minimally invasive surgery for complex cases. And fourth is the credentialing complexity. Steep institutional requirements for safe rollout include simulation training, proctored cases, ongoing competency assessment. So, what are the clinical applications across the gynecological specialties? For the benign gynecology, robotic-assisted total hysterectomy is the highest volume application. Myomectomy for complex fibroids provides value by enabling precise reconstructive suturing, preventive uterine architecture, and optimizing reproductive outcomes. In urogynecology, robotic sacrocolpopexy is a standard approach for apical prolapse, demonstrating shorter hospital stays and reduced blood loss and equivalent functional outcomes due to enhanced 3D vision and wristed instruments facilitating precise mesh replacement. In oncology, for gynecological cancers, robotic surgery facilitates comprehensive surgical staging and radical hysterectomy, often utilizing sentinel lymph node mapping. It achieves oncological evidence for selected cases with reduced perioperative morbidity. In reproductive surgery, robotic surgery supports fertility-preserving procedures like complex myomectomy and deep infiltrating endometriosis excision. Its precision aids meticulous dissection and hemostasis, leading to meaningful reproductive outcomes. What the evidence actually show? There is a systematic reviews and meta-analysis in the current consensus. Over the past decade, the evidence base for robotic surgery has matured, with numerous high-quality systematic reviews and meta-analysis clarifying the clinical outcomes. The consensus reveals consistent findings that guide clinical decision making across the gynecological specialties. The first evidence is operative time and cost considerations. Robotic approaches consistently results in longer operative times and higher direct costs, especially during the learning curves. However, higher volume centers can achieve cost effective through reduced complications and shorter hospital stays. Economic efficiency is improving as technology advances and surgeons' experience grows. And there is an equivalent clinical outcomes comparative to the conventional laparoscopy in complication rates and recovery time or patient-reported outcomes. Both approaches yield excellent results for appropriately selected patients. Enabling complex minimally invasive surgery, the most significant advantage of robotic surgery is its ability to extend minimally invasive approaches to patients with complex anatomy, severe obesity, large fibroids, and extensive adhesive disease. This capability allows many patients to avoid laparotomy, leading to reduced pain and faster recovery. Oncologic safety and efficacy. Short and mid-term oncological outcomes are broadly comparative for selected endometrial and cervical cancer cases. Robotic platforms facilitate comprehensive surgical staging, including lymphadenectomy safely. While some high-quality randomized trials are still limited, ongoing studies refine appropriate patient selection criteria for optimal oncological outcomes. And now we are having four global current robotic platforms. One is the Da Vinci, and second is a Medtronic Hugo Ras, third is a surgical Vercius, and fourth is the Ansensis Surgical Senhance. These are the four robotic platforms available throughout worldwide. And adding to it, the recently in 2017 SSI Mantra Robo is innovated by Indian cardiac surgeon Dr. Shruti Srivastav. It is approved in India and Nepal for gynecological, general, urological and oncosurgery along with the telesurgery. The Da Vinci, the surgical robotic system. In this context, I want to tell you about the father of the robotic surgeon is Dr. Frederick Moll. It is the first surgical system is innovated by the Intuitive Surgicals of USA. Now the Japan is also included in it. The Da Vinci surgical system, the latest version is XI5. It is a closed circuit console and it is approved by the FDA in 2000. So this is a video. Short clipping of 2.5 minutes video showing the surgical Da Vinci robotic system. It has a master console, closed console with 3D HD vision and the patient cart and vision system. Patient cart has 4 robotic arms which helps in placing the ports and also for the visualization of the internal organs of the abdomen. And vision cart is placed near the patient cart. This Da Vinci surgical system has an old innovation of Intuitive Surgicals. Its cost about 2 millions and the Da Vinci is having a higher safety rates and randomized control trials for the robotic gynecological surgeries. The oncological surgeries, oncological surgeries has had to be approved. Now the latest innovation is single port systems with AI integration, and tissue pressure is low with the latest Da Vinci systems. But there is a pitfalls with the Da Vinci. The one is the communication is difficult when we are operating on the consoles because of the closed console. And second, it is a space occupying. So I'm unable to show the video demonstration of it. So next we can proceed for the Medtronic Hugo RAS. It is also innovated by the USA. It is approved by the FDA in 2021. It is similar to the Da Vinci, but is an lesser 1.2 to 1.5 million. But it is not yet approved by the FDA in 2025. Maybe it will be approved at the later stages of the 2025. And second half, we can get approval. And it is useful for the urology and benign gynecology and surgical cases. It has a portable ports and also the open console. And third is the CMR surgical Versius. It is innovated in 2014 by Paul Robson and Martin Duke, Cambridge of UK. And in 2021, it is acquainted by the Australia Macquarie University. It is also an open console. Now GE is invented in CMR surgicals. And the fourth and latest is the Essentius Surgical Senhance. It is a global and it has a most advantages. The part of Karl Storz was also invested in the surgical Senhance robotic system. It is about $1 million to the $1.5 million. It is FDA approved in 2019 by Anthony Fernando, is a partner of surgical Senhance system. It is also an open console. Its head office in North Carolina, Durham, and USA. The advantages of surgical Senhance, it is a midway between the laparoscopy and robotic systems, but it has a reduced operative duration comparatively than the Da Vinci, and tactile feedback is better. Independent arms, easy to locate operatively, and post-operatively liver function tests are normal. Eye tracking camera control is better, and ergonomics are better. Now it extends to the Europe and Japan. The ports are 3 mm and 5 mm reusable instruments. There is a digital fulcrum and smart eye tracking. Wherever eyes moves, the operative field, the camera follows. And augmented intelligence, clear picture before surgeons move. Advanced innovation, with the innovation and integration of AI and ML, digital tagging of anatomical areas provides visual instruction for enhanced communication and coordination for surgical techniques. Now the latest trend is single port revolution. In single port, 25 mm port, the 4 instruments with a camera and 3 accessory instruments for the surgical equipment. With these, in a single port, with the 4 equipments in a single port, we can operate. It is beneficial in cosmetic purpose and post-operative recovery. 2 minutes. So what's changing now? From 2025 onwards, there will be a single port robotics maturation and commercial competition intensifying because lot of robotic systems entered into the market, and there is a telesurgery transition to reality, and artificial integration accelerating makes the surgeon's operative skills will be more easier and precise. Regulatory evidence and frameworks are evolving with NICE and national bodies are creating new frameworks for systematic evaluation of multiple robotic systems. This shift reflects the market maturation and payer demand for comparative effectiveness data, guiding adoption and reimbursement. And the next level of surgical revolution and AI, there is an autonomous camera control, instrument and anatomy tracking, surgical face recognition, and an autonomous subtask execution. The visibility and visualization allows surgeons to concentrate entirely on tissue manipulation. And there is a preclinical validation of autonomous suturing, tissue resection, and vessel sealing in animal model points towards partial surgical autonomy. For the ensuring adoption and credentialing, there is a simulation virtual reality training, proctored clinical cases, and dry laboratory practice, volume thresholds, and maintenance. What are the economic aspects of the robotic surgery? The cost, value, and access. The $2 million average capital investment and $200K million annual maintenance and $3,000K per case disposables and 150 plus annual volume thresholds. And future directions and in next 5 to 15 years, near term in 2 to 5 years, AI-assisted surgery becomes the standard. And in mid-term in 5 to 10 years, telesurgery and global expertise sharing. In third, long-term 10 to 15 years, supervised autonomous surgery. In 10 to 15 years, personalized data-driven surgery. The robot can assist the surgeon for precision and skills, and future moves can be known earlier.
Dr. Sumana, sorry to interrupt. I think we are running late and we need to give Dr. Usha time to talk.
Yes. This last point I want to tell you. Close it. Yes. The evolution is augmented reality and image fusion, the smaller and more flexible systems, 5G and cloud connectivity, haptic feedback and force sensing, energy-based instruments. Yeah, I'm closing it. So the future research priorities are long-term oncological outcomes requiring 5 to 10 years of follow-up, patient-reported outcomes beyond clinical metrics, learning curve characterization of AI-assisted systems, cost effectiveness, analyze the diverse healthcare settings, and impact of haptic feedback on surgical performance, telesurgery network, latency threshold for safety. So in a future is the robotics. The half of the work of the surgeons is taken over by the surgical robots. Thank you for the patience hearing, one and all.